Today's pharmacology topic is nonsteroidal anti-inflammatory drugs, also known as NSAIDs. First, let's talk about what causes that pain and inflammation that occurs with tissue injury. As you can see in this image, when a cell is injured, arachidonic acid, which is a phospholipid in the cell wall, is released. Arachidonic acid is now exposed to an enzyme known as cyclooxygenase, which converts arachidonic acid into various prostaglandins. Now, prostaglandins have many different roles in the body. For one, prostaglandins cause vasodilation and increased vascular permeability, leading to fluid leaking out of the vessel and into the tissue. This contributes to the development of inflammation. Prostaglandins also stimulate the nerves to send impulses to the brain that will make you feel that pain. In addition to producing the prostaglandins, which contribute to pain and inflammation, the cyclooxygenase or COX enzymes also play a few other roles in the body. Now, these roles depend on the type of COX enzyme that is present. There can be either COX-1 or COX-2. Now, COX-1, which is present in most tissues, produces prostaglandins, which are responsible for protecting the GI mucosa, as well as promoting renal vasodilation to help maintain renal blood flow. COX-1 enzymes also increase the production of thromboxane A2, which promotes platelet aggregation, a necessary step in the body's ability to clot. On the other hand, COX-2 enzymes are primarily produced at the site of tissue injury to cause those effects that we previously discussed. So they sensitize pain receptors, making the brain feel more pain, as well as produce the prostaglandins, which mediate the inflammatory response. Now, you can see from these roles that many people think of COX-1 as the good COX, while COX-2 is thought of more as the bad COX. Now, NSAIDs work by inhibiting COX-1 and/or COX-2 enzymes. By blocking the activity of these enzymes, the production of those prostaglandins we just discussed will also be inhibited. As you can see in this image, the blockade of COX enzymes will help to reduce pain, inflammation, and fevers that are mediated by prostaglandins. Unfortunately, this also means that some of those protective effects will be inhibited as well. Now, what's important to note here is that not all NSAIDs work the same. They have differing levels of inhibition of the different COX enzymes. Some NSAIDs are non-selective, so they inhibit both COX-1 and COX-2 enzymes, while other NSAIDs are selective and they'll only inhibit the COX-2 enzyme. Non-selective NSAIDs include aspirin, ibuprofen, naproxen, ketorolac, diclofenac, and indomethacin. Now, just because these NSAIDs are all non-selective, it does not mean they all have the same effect. Among these non-selective NSAIDs, each will have a varying degree of inhibition of the COX-1 versus the COX-2 enzyme. Some will favor either COX-1 or COX-2, while others have more of a 50-50 split. For example, aspirin has a much greater COX-1 effect rather than COX-2, and this really dictates how it's used clinically. Because of this, you may see differences in the beneficial effects as well as the adverse effects of each individual NSAID. Selective NSAIDs include celecoxib. Remember, this NSAID only blocks the COX-2 enzyme. So all of those beneficial effects of the COX-1 enzyme, including protection of the GI mucosa and platelet aggregation, will remain unaltered. This means selective NSAIDs will avoid some of those adverse effects associated with non-selective NSAIDs related to COX-1 inhibition, including GI ulceration and bleeding. Now, I'm sure you've seen and probably used NSAIDs yourself, so you're probably familiar with one of the most common uses of these drugs for pain and inflammation. There are several conditions which are associated with significant pain, specifically due to inflammation, for which NSAIDs are often used. Rheumatoid arthritis is a chronic inflammatory disorder that can affect many joints. NSAIDs can be used with disease-modifying medications to help with symptomatic management of that painful swelling. NSAIDs can be similarly used for symptomatic relief in juvenile idiopathic arthritis, which is a form of arthritis that can affect children. Significant inflammation is also associated with the urate crystal deposits in gout, so NSAIDs are one option that can be used to treat an acute gout flare. Clients with osteoarthritis may also find symptomatic relief with the use of NSAIDs, as these clients will have significant joint pain due to the lack of cartilage between their bones, as well as swelling from that soft tissue inflammation around the joints. NSAIDs can also be used to reduce fevers that are caused by a variety of bacterial or viral illnesses. Primary dysmenorrhea, or painful cramping during menstruation, occurs due to prostaglandins in the uterus, so NSAIDs are useful to help relieve these symptoms as well. And finally, clients with dental pain may find NSAIDs useful, as much of this pain is often associated with swelling and inflammation. Unfortunately, NSAIDs are not without their risks. Because of the protective role of COX-1 enzymes in the gastrointestinal tract, COX-1 inhibition can lead to harmful GI effects. This disruption of the GI mucosa can lead to esophagitis, which can cause symptoms of heartburn. It can also cause gastritis, which can lead to the formation of a gastric ulcer and ultimately hemorrhage if not appropriately treated. The severity of these GI symptoms can range anywhere from mild to fatal. And because the risk of developing these adverse effects increases with duration of use, it's important to limit the consistent use of NSAIDs if possible. The interference with platelet aggregation secondary to COX-1 inhibition can lead to prolonged bleeding time due to the impairment of the body's clotting ability. Of course, this risk of bleeding can be increased if clients are also taking other medications that increase the risk of bleeding, such as anticoagulants. Now, inhibition of COX-1 and COX-2 enzymes will also block the renal vasodilatory effects that help to ensure renal perfusion. This puts clients at an increased risk of developing an acute kidney injury due to vasoconstriction in the renal afferent arteriole. This leads to decreased blood flow through the nephron. Now, there's one adverse effect that's specific to COX-2 inhibition, so this is especially relevant for those selective NSAIDs, given their high potency of COX-2 inhibition. Blocking COX-2 can lead to a reduction in prostacyclin, which is the prostaglandin in the vascular endothelium. This reduction increases the risk of vascular injury, which is thought to contribute to the increased risk of cardiovascular events associated with NSAIDs. This includes acute myocardial infarction and stroke. The only exception here is aspirin, which is used in clients with atherosclerotic cardiovascular disease to decrease the risk of these cardiovascular events. Remember, these events are caused by a plaque rupture with subsequent thrombus development that blocks blood flow. So the antiplatelet effects of aspirin will help to prevent that thrombus formation and avoid the disruption of blood flow. Finally, NSAID use can cause complications in pregnancy, especially if used in the third trimester. They can cause premature closure of the ductus arteriosus, which is the connection that allows oxygenated blood to flow to the baby while bypassing the lungs. NSAIDs can cause premature closure of this connection, which can lead to heart failure in the baby. NSAIDs may also cause renal dysfunction in the fetus, leading to reduced production of amniotic fluid. Now, there are a couple of unique syndromes that are associated with aspirin specifically. The first is salicylate toxicity. Aspirin is derived from salicylic acid and is considered a salicylate. Increased exposure to salicylates can lead to a specific and unique constellation of symptoms, which may be life-threatening. As you can see in this image, many organs can be affected. Early clinical signs of this toxicity include GI side effects such as nausea, vomiting, and abdominal pain, as well as tinnitus or a ringing sound in the ears, as well as dizziness and confusion. Clinical features that may occur with more severe toxicity include hyperventilation, which can lead to a respiratory alkalosis as too much carbon dioxide is blown off. And significant buildup can also cause metabolic acidosis, because remember, salicylates are acids. And finally, it can cause alterations in mental status, such as agitation, confusion, and seizure. Now, the antidote for a client with salicylate toxicity is a dose of activated charcoal, which will absorb any salicylate remaining in the GI tract. The other syndrome associated with aspirin is specifically seen in children, Rey syndrome. This is a rare, life-threatening syndrome that can occur as a result of giving aspirin after a viral infection, such as flu or chickenpox. Because children may have a viral infection without even knowing, it's generally recommended to avoid all aspirin use in children and teenagers if possible. Acetaminophen or another NSAID, such as ibuprofen, can be used in children if needed for pain or fever. Now, as you can see in this image, Rey syndrome can result in swelling of the brain, leading to cerebral edema and encephalopathy, as well as swelling of the liver, leading to acute liver failure. This syndrome can rapidly evolve from the early symptoms of vomiting and confusion to respiratory depression, leading to respiratory acidosis, seizure, coma, and even death. Clients should be taught to take NSAIDs with food to minimize GI adverse effects such as nausea. Clients should also stay hydrated while taking NSAIDs to decrease the risk of kidney injury that may occur due to decreased perfusion of the kidneys. If a client has renal impairment, then NSAIDs should be avoided if possible to prevent worsening of that renal disease. Because NSAIDs can cause GI injury, including ulceration and bleeding, clients should be taught to report any black tarry stool to their provider, as this may represent GI bleeding. Aspirin use specifically should be avoided in all children due to the risk of Reye syndrome, and all NSAIDs should be avoided during the 3rd trimester of pregnancy due to that risk of premature closure of the ductus arteriosus in the fetus. Aspirin use should be discussed with the healthcare provider prior to any surgical procedure, as aspirin will typically need to be discontinued several days prior to decrease the risk of bleeding. And finally, clients with a known allergy to sulfa should avoid taking celecoxib, as similarity in their chemical structure increases the risk of causing a similar reaction.